Thank you. Well, first, I just want to say good morning and thank you to Dr. O'Keefe for inviting me to present in front of such a large primary care audience. It's a real honor to do this. I've been asked to talk specifically about COVID-19 and return to more strenuous levels of exercise, either for recreational or competitive athletes. I do have several disclosures, some affiliations with teams, organizations, which could be relevant for the content of this talk. You also can see my research funding sources. So I have four primary objectives for everyone by the end of this talk. One, just to, again, remind everyone of the strong association between COVID-19 infection and adverse cardiovascular sequelae associated with infection. I think it's important to differentiate the competitive athlete and the quote unquote non-athlete. This can be a bit of a gray distinction, but one that is important, and we'll try to do this as best possible. Of course, focus on return to exercise or play as the primary objective, but also emphasizing many of the limitations, the unknown. There's certainly a substantial amount that we don't know, and we're trying to do the best we can with the evidence we have at present. March 11th, 2020, I think certainly for the sports world, this is when the pandemic and the national shutdown really really got some life. Certainly for many in the general population as well. I think the shutdown of sports really put the pandemic and shutdown into certainly into the forefront. This was a routine NBA regular season game between the Utah Jazz at the Oklahoma City Thunder, and in very dramatic fashion, the game was canceled when one of the Jazz was disclosed he tested positive for COVID-19. And then in rapid and subsequent fashion, across the US, iconic American sporting events were either canceled or postponed. So 2 months, 3 months later, we're certainly aware that COVID-19 is with us for the foreseeable future, unfortunately. When we think about exercise and return to competitive type sport participation, it's the association with cardiovascular sequelae that certainly heightens our concern. We know that among hospitalized patients with COVID-19, there's a very high prevalence of acute cardiac injury, roughly around 20 to 30% based on which report or study you look at. And to put this into some context, when we look at other viral infections, some of the common viral infections that we all know about, at worst, about 1% of the time will you see evidence of acute cardiac injury. So there's clearly a predilection for the heart as it relates to more serious levels of infection. When we think about the competitive athlete, it's important to just try to distinguish between the quote unquote non-competitive athlete or somebody in the general population. We know that certainly competitive, professional, collegiate athletes fall into that category. When we think about recreational athletes, the line in the sand can be a bit gray, but certainly the recreational marathon runner, the triathlete, the cyclist, the hardcore CrossFit athlete, or somebody who regularly goes to Orange Theory. These are clearly individuals that would fall into that category. And other individuals, again, probably a little bit gray, but that's at least some way to start distinguishing between these two different populations. And why this is important is when you think about somebody engaged in very high levels of physical activity, again, thinking about how a viral infection can impact the heart, we of course are very concerned about myocarditis, direct viral invasion of the heart, intense physical activity, potentially precipitating dangerous ventricular arrhythmias, and of course, sudden cardiac death is one of our more common causes of sudden cardiac death in competitive athletes. So with what we're seeing among hospitalized COVID-19 patients we have a heightened awareness of the potential cardiac concerns that could be present among more high level athletes. So over the last couple of months, we were asked by various organizations, teams, leagues to comment on the return to play for the athlete, understanding that this was going to become a significant issue. So the American College of Cardiology, our Sports and Exercise Council, along with several national leaders, put forth these expert consensus recommendations. So there's a few caveats. Number one, this was not a statement intended to guide public health policy. We're not talking about a return to sport. Again, not meant for a routine return to exercise. And I'll have a couple comments about this at the very end. And again, acknowledging the significant limitations that we know we have at present. We don't know the prevalence of asymptomatic COVID-19 in the community, and the prevalence of cardiac injury in asymptomatic or more mildly ill COVID-19 infected patients also unknown. So whether what we're seeing among hospitalized patients translates to these more mildly ill patients is unknown. But at present, we felt it was important to have a more conservative approach to the return to strenuous levels of exercise. So this is a busy slide. This is our algorithm, but actually fairly easy to walk everyone through. We'll start at the left side of the screen, COVID-19 negative and asymptomatic individuals. Certainly we know some individuals can be tested if there is exposures or whatnot, just to acknowledge that with no symptoms and a known COVID-19 negative status, really no limitations to exercise. Now, what of course is not addressed in these guidelines, and probably I think more a public health issue, is that COVID-19 unknown status, as well as being asymptomatic, and that clearly represents an important issue that we're unfortunately faced to deal with, that we're dealing with at present. COVID-19 positive and asymptomatic individuals, we recommend no strenuous exercise training to coincide with the strict isolation period. If more mild symptoms develop, again, 2 weeks of no exercise upon resolution of symptoms. And here's where we see the introduction of our more conservative recommendations. Again, based off of what we're seeing among inpatient COVID-19 individuals and the concern for potential cardiac injury. So recommending an ECG, cardiac imaging with an echocardiogram to assess left ventricular systolic function, as well as cardiac biomarkers. And if there is evidence of cardiac injury suggestive of myocarditis, following the ACC/AHA guidelines for return to play for myocarditis, which is 3 to 6 months of no exercise training followed by risk stratification. Furthermore, for the sicker individuals, those who required hospitalization, we recognize that many of these patients will actually have testing in the hospitals to base the initial algorithm off of. For those that had normal imaging, 2 weeks of no exercise training after discharge, followed by a comprehensive medical evaluation by a sports cardiologist or a cardiologist or a physician, with consideration of convalescent testing based off of individualized cases. For those individuals who are found to have evidence of myocarditis or cardiac injury during the hospitalization, again, following those myocarditis return to play guidelines. So we can see the conservative nature of these recommendations. So there are several take-home points upon reviewing these. Number one, again, understanding that the conservative nature of these recommendations really comes from what we're seeing among hospitalized patients. This predilection for cardiac injury, a very high prevalence of cardiac injury for these sicker individuals. We just don't know whether this translates to the lesser ill COVID-19 patient, but for those engaging in strenuous levels of exercise, of course, the stakes are very high as it relates towards potential precipitation of cardiac morbidity or death. So we have a heightened awareness of what we're seeing among these sicker patients, and that leads to the conservative nature of the recommendations. And we acknowledge that really what we need, of course, are more research, future data, which will help determine the most appropriate risk stratification, potential relaxing of many of these guidelines potentially in the future. And when we think about, as I mentioned, the comment about those engaged in just routine levels of exercise out in the general population, of course, the majority of patients that you're going to see, I would say that for those who are asymptomatic or mildly ill, probably not necessary to engage in this degree of intense risk stratification, but to acknowledge that there should be a slow resumption of exercise, ensuring that there's no new symptoms. And of course, there's going to be a period where these individuals are not going to be feeling great as they're recovering, but they should be able to get back to those 150 minutes of recommended moderate activity based off of AHA guidelines without further risk stratification. If there is underlying cardiac morbidity in these patients, certainly involving the cardiologist makes the most sense as it relates towards getting back to these regular levels of exercise. Again, need more data with that, with of course this population as well. With that, thank you very much. If there's questions, there's my email address, Twitter handle as well. I just want to quickly note, I know this is a primary care audience, but we do have our Care of the Athletic Heart Conference. This is sponsored by the ACC. It's on June 20th. We're virtual this year, so it's a truncated agenda. There may be some core components of the education that primary care physicians, internists, I think would be interested in as it relates towards taking care of athletic individuals. But we do have a COVID-19 and exercise panel specific for this virtual agenda. Again, this is a broad discussion, not just focused on cardiology. And so if there is an interest in this based off of this talk, as well as patients that you may see, check out the website and certainly register. And we hope several of you will. And with that, I'll stop. Thank you very much.
Let's see, similar to last time, and I don't have a clock front and center, but let's go through it. So this is our sports cardiology and a case. Thank you to Dr. Kim again for speaking, and just a reference to his article. So for my case, it's going to be for educational and practice review purposes, and this patient gave me permission to present it. Basically, the learning objectives are to look for possible cardiac manifestations in our low-risk patients and to promote proactive clinical follow-up. The patient is a 23-year-old female nurse technician with ADD and seasonal allergies. She called on her 6th day of symptoms with an inflamed, burning nasal sensation and loss of taste and smell, a small rash, as described here, and a previous COVID-19 exposure. She had a drive-through screening test. At that point, she had cough, sore throat, chest tightness, nausea, and mild shortness of breath, followed by a VOMC video visit. And she said, really things felt like typical allergies, except noticeably different with the decrease in taste and smell and chest tightness with walking. She was deemed to be low risk and followed by telemedicine. She received 5 calls over 10 days and symptoms were mild and improving. She did develop some arthralgias and she agreed on day 20 to being discharged. So here's some follow-up after her discharge from the virtual clinic. She reports that she felt like she was getting better, but she was still inactive and resting. She started studying for her school exams and she took her usual dose of Adderall for 2 days in a row on day 25 and 26 around midday. And both of those nights she stayed up late sleeping and had less than 5 hours of sleep. On day 27, she woke with a pounding sensation in her chest and a return of some of the chest tightness that she had had 2 weeks prior. She found that her heart rate in bed, she used her portable pulse oximeter, it was around 100. And when she stood up and walked, it went to the 140s. That persisted throughout the day. She felt fatigued, mildly short of breath with walking, and she had no fevers or chest pain. She called the COVID hotline with that information the next day. She slept 12 hours that night. She stopped all medications and caffeine, but she didn't feel any better. Now she was starting to feel anxious about it. So they referred her to the outside emergency room near her home. In the ER, her oxygen saturation was 100%. She had normal resting vitals. This is her seated vitals, and then her standing vitals. So her heart rate did go from 84 to 110. They gave her 1 liter of fluid and rechecked. Here her blood pressure did not drop. Her heart rate did go from 71 to 92. They didn't record the duration of time from seated to standing. They did labs, which were generally normal as listed. Her D-dimer was 610. Her repeat nasal PCR was done there and it was negative. Her EKG was within normal limits. The heart rate was 97. Her chest X-ray was normal and CTA of the chest showed a few nodular opacities. She appeared comfortable and so she was discharged home with instructions to rest and hydrate. We saw her in the virtual clinic again because of this ER visit, and she reported really no change. Heart rate was in the 90s at rest, and if she got out of bed, it would be around 105 to 110. No change after a couple more days, and getting a little better on day 37. So she was again discharged from the virtual outpatient management clinic by the team following her. She returns to work at the hospital on day 44, and walking from the parking deck, she noticed pounding in her chest and took out her pulse oximeter. Her heart rate was 182. She waited a few minutes, it came down to 140, and she was actually able to get to work, sit down for a while, and here's where her heart rate landed. She continued working and did 3 12-hour shifts over the next 3 days and was able to do it without significant symptoms. Her other reported symptoms when we called to follow up, she said she's only able to do 1 push-up and she hasn't returned to her usual baseline exercise levels. She also noticed ongoing arthralgias and some word finding difficulty. So it just gave me an opportunity to touch on the fact that we've heard about some of these acute manifestations, and I've provided a reference here of cardiovascular dysfunction, but we haven't heard a lot about the mild cases or the prolonged follow-up. So I was going to present just two brief case series from the original SARS in 2006. 121 patients were followed. These were healthy people generally, a lot of healthcare workers who had pneumonia. And when they checked with these folks several weeks later, they found that there were still 35% of them were tachycardic despite resolution in fevers and hypotension. So here's just a table from that showing the pulse rate on follow-up for these patients, not going down over the weeks of follow-up. So just sort of provocative, interesting. They said it could be a result of autonomic tone. Of course, there was another paper with a different theory. This was 15 consecutive patients who had fairly severe SARS illness, and they were followed up in a clinic where they had a substantial workup, including PFTs and echo. So pretty long length of stay for this group of patients. And I'll just point out that their conclusions were different. When they looked at their nighttime heart rates being normal, daytime tachycardia, and some quality of life complaints from the patients, they concluded that physical deconditioning and psychological well-being were the reasons, as opposed to a primary cardiovascular or autonomic cause. So just something to start to pay attention to in our patients. I wanted to present the case. I'll again thank our guest speaker today, and anybody that has interesting or useful cases, feel free to volunteer. Thanks everybody for coming.